Hey guys, good morning. Just want to do a review of our discussion topic from last week, which was the classification system for neck pain. It is not perfect in any way, but I think it's something that can help you provide you a framework for guiding your examination and then subsequent management, which we're going to be talking about in the next several weeks. So if we think about the classification system, we start with the triage, where we determine is there any red flags? Is there a reason why we should refer this patient out? Or are they appropriate for physical therapy? So we kind of talked about that last week, screening for the red flags. And then the second step would be staging the patient. Are they acute, subacute, chronic? How much irritability is there? The other thing we should probably also consider at that point is what is their risk profile for poor recovery? So that would be some of the prognostic factors, particularly when we start to think about like whiplash or traumatically induced neck pain. That's where most of our information is from on prognosis. Patients coming in, and this would also apply to patients that atraumatic neck pain, patients coming in reporting higher pain, higher disabilities, more psychosocial variables such as fear of movement, pain catastrophizing, general distress such as like maybe post-traumatic stress if they've had trauma. These are patients that are going to have a harder time with recovery. And I think we can generally identify those patients, or we should be doing some screening to identify those patients up front. Probably going to need to take a little bit of a different tact with them and maybe even adjust our treatment programs to account for their poorer prognosis. We'll be talking about this in subsequent weeks. So I think you guys did a good job. Kind of, you each picked a patient and applied the classification system to them. Some good things came up related to that. Let me just see, I wrote those down here. One was, can we streamline our examination? So at the postgraduate level, one of the things we want to do is start to refine our exam to really only include those tests and measures that are going to help us with either ruling something out like a red flag, ruling in the diagnosis that is on our hypothesis list, and then in general, is it going to guide our management? That's probably one of the more important things to ask yourself. Is this test that I'm using actually the results of it going to change what I'm doing with the patient? Will it affect my treatment? And if you kind of apply that filter to some of the things you're testing, you're probably going to find that you can omit many of the things, at least at the initial evaluation. Then that would be the other thing is, are there certain tests on day one that you need to do, others that it probably is either going to take too much time or maybe that patient's too irritable where you can save that for down the road. So things to think about with that. The other thing we talked about is, patients' reliance on passive treatments. I think Justin presented his case where a patient had lots of different passive treatments in the past. Very, very common, particularly with spinal disorders. For whatever reason, we tend to treat that with a lot of like manual therapy and acupuncture, cupping, whatever you want to call it. So in general, a lot of our patients show up on our doorstep having had a lot of those things, which is fine for us to maybe initiate treatment with, but we eventually want to get that patient into more of their own active self-management, which as PTs, that's kind of our bread and butter, and we just need to keep that in the forefront. So this week we're going to be talking about manual therapy. That even though I just kind of said that we need to kind of wean patients away from it, it's a very valuable technique. We're going to be talking, kind of focusing our discussion around the decision making behind manual therapy and how you choose what you're going to do with your patient. So look forward to our discussions this week, and thanks for a great week today.